We are talking about sudden cardiac arrest on the pitch today, and it builds on the lecture that Nathan Riding did a couple of weeks ago about, now let me just see if I can move this along. There we go. Which really touched on the question about how can this still happen in 2021? You know, we have cardiac screening and we spend a lot of time and effort doing cardiac screening, and yet this still happens. So Nathan's discussion was more about the strengths and the weaknesses of cardiac screening. We are going to build on that, and specifically with more of a focus on this World Cup that's coming up next year for Qatar. So with that in mind, apologies for this. There we go. I would like to say that we don't have any conflicts of interest, and of course we will not be discussing any drugs or any other products in this presentation. And that our focus for this presentation will be on cardiac screening for athletes and also the important aspects of managing sudden cardiac arrest on the pitch. So, as you already mentioned here, Paul, the reason why this is actually quite a timely discussion now is because, as most of you know, a couple of weeks ago, Christian Eriksen, who's a 29-year-old Danish midfielder, had a sudden cardiac arrest on the pitch. And this was a classic non-contact collapse in the 42nd minute of the game. So he was resuscitated on the pitch by a very experienced sideline medical team in front of 15,000 shocked and traumatized spectators. And then he was taken off the pitch and he was stabilized in hospital. And as we all know now, thankfully, he survived this. But of course, it wasn't just the 15,000 local spectators that were traumatized. The Euro 2020s were, is predicted to attract almost 2 billion TV viewers by the time we get to the final. And these people were all pretty traumatized as well. And you can be sure that the few minutes of this match will be watched in the weeks and months to come by many people, even those who weren't watching the match. And I'm sure it's going to make it onto the lecture circuit for the next few years. And the big question that people are asking is, how is this possible? This is a professional footballer who's played for 3 really big clubs and has been representing his country for 10 years already. So he must have had at least 15 years of a regular cardiac screening. And still, it wasn't possible to predict this event. And the second question is, given that the survival rate of sudden cardiac arrest outside the hospital is around about 10%, how is it possible that he survives this? So to discuss these two things, I'm going to introduce you to 2 of my colleagues. Both of them have been team physicians at a football World Cup, and both of them have also been FIFA medical officers at a major tournament. So they have a really good understanding of the issues involved with this from a number of different angles. Ian is also currently our acting clinical lead in the athlete screening department at Aspetar. And Celestia is working with the Supreme Committee for Delivery and Legacy here in Qatar, preparing medical teams or for the provision of medical services for the 2022 World Cup. And you can imagine this whole thing is a big issue for us because we understand the major exposure that comes from an event like this. And also we need to make sure that we're prepared for it. So afterwards, we will have the panel discussion as Paul explained. And I will leave it to Ian at the end of the presentation to introduce our panelists to you. So without further ado, I'm going to hand over to Ian. Thank you.
Many thanks, Liesl. Yeah, good introduction. And as I told you, I was sitting on the settee shouting at my computer screen where I was watching the game because this definitely looked like a sudden cardiac arrest. Marvelous. So just to talk a bit about screening, although, at the moment, our real head of screening is on vacation. So it falls to me and Steve Target in the department to sort of look after any problems that happen in screening. But, cardiac screening was pioneered by Corrado in northeastern Italy. And it was evident that they could reduce the problems encountered by athletes by screening them with, and in this case, by questionnaire and ECG. In Aspetar, we have an athlete screening department, and I've over the years, I've screened hundreds of footballers at different clubs and at different situations in the UK, and it's always a runaround because nowhere have you got an elite cardiac screening unit with an MRI scan, with other colleagues, and with other things that you need all in the same place. So we have that here at Haspetar. It's a really unique place. One of the things that really impressed me when I first came. And as far as cardiac screening goes, ECGs, echoes, 24-hour monitoring, stress testing, and cardiac MRIs are all carried out here, which is a great thing for the athletes. And as you know, we screen all our registered athletes in Qatar, so that's quite a lot. So we have a throughput that's pretty impressive in the screening department. Next year, we've got 32 teams coming to the World Cup, and that's 736 players. If you consider there's 23 per squad, there will be add-ons and stuff like that. And there'll be coaches, medical staff, loads of people coming, but players we're talking about 750. Now don't you, if you've been involved in this, that FIFA mandate cardiac screening as part of the pre-competition medical assessment. And we all think that's a good thing, even though actually to do it when you're waiting for a squad to turn up can be difficult and a bit of a hassle. Now we also know that any manager will pick his squad, and a couple of the players, one or two, might get ill, might have an injury, something might happen, and they drop out of the squad, and you have a late addition. That late addition may not get screened in time. And so what you're doing is you're turning up at a venue looking for a cardiac screen or some sort of screening process. And we'll be able to hoover them up. And that will be relatively straightforward for us. And like I said, we've got an elite setup here, and we're really looking forward to being available for these athletes and for these teams so that everything can be done properly. But what if we uncover issues at the last minute? You're now 2 weeks before the tournament starts, and someone tells you that your player you've just called up has a cardiac issue. Can we exclude them? Should we exclude them? Or we might have to just advise what the risk might be. And screening is all about risk mitigation. It often isn't about yes or no. It's about saying yes, you're fine to play, but now if you've got a sore knee, you might be able to play and train with that, with some sort of adjustments on your training schedule. But if you've got a sore heart, that might not be possible. And so we'll have a what if plan mapped out in case of this. And we've got to do that because, and this is the reason why. So out of these 4 players, I knew 3 of these really, quite well. Fabrice Muamba, in the bottom right, he was a young player at Arsenal when I was there, and he was screened every year. Michael Carrick, he was an England player when I was with England. We screened him every year, and I know for a fact, because I talked to the Manchester United medical team all the time when I was with England, he got screened every year there. Ugo Ekiog, I didn't know him that well, but I looked after him at a match that he played on behalf of the Football Association against the Army. Again, all these players will have been screened loads of times, as Liesl was mentioning. And the last one is Christian Eriksen, of course, thankfully survived. But I got in touch with a Spurs doc who I know really well from the UK. He said what a nice bloke he was. I said what a difficult thing it was. He said, yeah, what a nice bloke. And I know for a fact, again, all these players are screened every year. So, we're going to uncover, sooner or later, we're going to uncover a problem in a difficult situation. In other words, when we're up against it from a competition point of view. So what will happen? It's going to be hard to include a player where everyone's looking all the time is he okay? Is he okay? Is he okay? Everyone's concentrating on the tournament. I don't know if you saw the France game last night. Crazy that they lost, but Hugo Lloris, who's the captain of France, was in the tunnel. And you couldn't have seen anybody more concentrated on what was going on than he was. My point of saying that is that these players are really concentrating on the game and the tournament. They don't have mental space to concentrate on, is my teammate okay? The player himself will be apprehensive. Who wouldn't be, for goodness sake? And as far as in-house media go, the club's media team will be going mad. The federation that they belong to will be going mad. And Aspetar, also the comms department here, you got to remember that the press will go mad because they're interested in the story. They come to the World Cup. The football's the football, and that unfolds as the tournament goes on. But what they're really interested in is the human story. And if this sort of thing happens, then that's the story they're all going to hinge on. Second opinions, will be phoning Mats or Jan up saying, can you have a look at these ECG? Can you have a look at this? Can you have a look at the cardiac MRI? Who do you know? Have we got another opinion on this, that, and the other? It's going to be crazy. And there'll be a sudden increase in demand. Players will suddenly say, oh, maybe I should have another cardiac screen. We're always interested in athlete care. That's what we do here, for goodness sake. And we'll always do the best for the athlete. And we're interested in making sure that we work with the World Cup team, Aspire Zone just across the way from us. And we want to work together. We want to work in partnership with the World Cup 2022 team to make it a success, for football really, but for Qatar as well. So Celeste, over to you.
Sailing in Doha can be very pleasant. And usually the weather is very good. But we all know that we're not going to go sailing without checking the weather report. And the reason for this is we know that the weather forecasters are actually very accurate in predicting most of the major weather patterns and storms which will come this way. But of course, we also know that even the best forecasters in the world can't predict exactly what's going to happen on the water when we get there. And particularly, they will not be able to predict when we meet Moby Dick, however rare that might be. And this is the reason why we never sail without our emergency equipment. And we also need to have the knowledge on how to use that equipment. So the point I'm trying to make here is that risk management is not only trying to prevent something from happening, but it's actually planning on what to do when that rare thing actually happens in any way. And the next 10 minutes or so, I want to talk to you about how we could, when the weather forecasters let us down, or the cardiac screening in this case, and we meet the cardiac equivalent of Moby Dick on the pitch, what do we do? But I'd like to take the opportunity to thank Dr. Peter Zendrowski. He's been teaching field of play and field of play courses to the Asian and the African football confederations. And he's allowed me to use some of his edited videos in this presentation. And this is the first one. Now, the first thing I want to say is, before we show, I've had a few videos, but I just want to point out that we need to walk a very fine line between consideration for those people who might be very upset about seeing these kind of videos and our sincere attempts to learn something valuable from watching them. So I would like to ask you to give these videos the respect they deserve and not to post them on social media. This is a medical forum, so we want to learn lessons rather than just gawk. So I think we all know this case by now, as Ian has mentioned him. No, Ian didn't mention this one, but this is Marc-Vivien Foe. And this was way back in 2003, Cameroon versus Colombia. It was in the FIFA Confederations Cup. And this was at 72 minutes. Foe went down. He just collapsed on the field of play. And what I would ask you to do is, while you watch this video, just try to imagine that you're the person who's responsible for his medical care. Now, that could be the team physician or the field of play teams or any of the people who were there, and how you would react if this happened. Now, I know that, bearing in mind, firstly, that the brain and the heart are very sensitive to hypoxia. And so you have about 3 or 4 minutes to do something to prevent irreversible damage. Now, of course, the easy thing to do is to sit back in our armchairs and be critics. And I know a lot of people have criticized this video. And this is not the reason why I'm showing you this video. This is not to criticize. This is to try and learn from this. And many people did learn from this. And so therefore, I only have 2 observations. The first is that this player, unfortunately, did not receive adequate resuscitation. And we can ask many questions about recognizing the cardiac arrest, about initiating the chest compressions, about defibrillation, and so on. But the people who really know the answers to these questions are really the ones who were on the pitch at the time. It's also possible that they didn't prepare, they were unprepared for this because it's a very rare event, and that they were just, I mean, people can panic, right? They can get to a point where they just don't know what to do. So the lesson we need to learn from this is that we need to anticipate this, and we need to be prepared to be able to do a better job than what was done on this occasion. So this is now the next video that I would like to show. And that episode that we've just watched was actually a huge turning point in the way that we manage and try to prevent sudden cardiac arrest on the pitch. And this video is, of course, of when Spurs was playing against Bolton at White Hart Lane, and this is Fabrice Muamba. He also had a sudden cardiac arrest on the pitch, and he had exemplary treatment. So if you look at this, you can see that within a minute, they started chest compressions. And at around about the 2 minutes mark, just after 2 minutes, he receives the first defibrillation. So this is what saved his life. And he actually received 3 shocks on the pitch and then another 12 shocks in the ambulance. And there was a very, very long downtime. But he survived. And the reason he survived was because of those first few minutes. And when we're talking about management of sudden cardiac arrest on the pitch, this is what we're talking about. It's about the first few minutes. It's not about the fancy stuff that happens in the hospital later on. It is what the team does in those first 2 to 3 minutes on the pitch. So there you can see already very effective chest compressions. That is just after 1 minute. Everybody knows exactly what they need to do. There's no panic. You can see this team has prepared for this. Somebody's in charge. Everybody knows what they need to do. Everybody has a role. Okay, so what's the difference between these 2 cases? And it's basically, literally, 3 to 4 minutes. 3 to 4 minutes of effective resuscitation. So how do we do to optimize our chances of survival, or the player's chances of survival when the player collapses on the pitch? And the first key point is don't panic. The second thing is keep it simple. And how do we keep it simple? We plan, we break it into these steps. We plan, we prepare, and we practice. And here's the first bit of good news. The planning has already been done. So this article was published quite a few years ago, and I know that FIFA is currently revising their field of play procedures, but the basics will remain the same. And this article describes the 11 steps to prevent sudden cardiac death in players. So just because a player has a sudden cardiac arrest doesn't mean that they have to have a sudden cardiac death. And it also describes the FIFA medical bag and its contents, which is standardized and which is used for all the FIFA tournaments. And the most important item in this bag, in my opinion, is the AED, the automatic external defibrillator. But of course, also the team who's been trained in how to use this defibrillator. And often people would ask, do this team need to be trained in BLS or ALS, so basic life support or advanced life support? And the interesting answer is that we are now noticing more and more that it may not be necessary to be ALS trained. In fact, there is this study beautifully demonstrates that, and this study was done in 33,000 out-of-hospital non-traumatic cardiac arrests. And bear in mind, this is not in athletes, this is in the general population. This was performed by Harvard Medical School between 2009 and 2011. But this is what they found, that those patients who were treated with basic life support, in other words, cardiac compressions and defibrillation only, had a much better outcome than those who were treated with out-of-hospital advanced cardiac life support, which normally includes advanced airway management techniques, IV access, and emergency medications. So just to clarify, the black line are those treated with basic life support, and the blue line, those with advanced life support. You can see the difference. The difference in survival rates is 13% compared to 9%. Now, I'm not saying that ALS in the hands of a competent person is not better than BLS. But what I am saying is that good quality BLS is as important, if not more important, than ALS in the initial stages of resuscitation. And the reason this is important for us to think about this is that BLS is something which can be taught to many different people, even non-medical staff at football matches. So this can be a very powerful tool in the battle against sudden cardiac arrest on the pitch and anywhere else. And this particularly in the lower leagues where you may not have formal field of play staff available. So these are then the 11 steps for the management of sudden cardiac arrest on the pitch, and we can divide it into 4 groups. There's the prevention part, the planning part, pre-match checks, and then performance. I don't want to spend too much time on the prevention because Nathan did a fantastic job a couple of weeks ago, and Ian has already spoken about it. But suffice to say, what we're really looking for here is structural pathology and the few others that we can detect with screening. But we also know that up to 23% of sudden cardiac arrest cases can occur in athletes with structurally normal hearts. And so even if you have a normal ECG and even a normal echo at screening, you can get false negatives. And of course, this is exactly, presumably, what happened with Christian Eriksen. So then we have to swiftly move on to the next step, which is planning and training. And here it's important to have a well-developed emergency medical plan and staff with the appropriate qualifications. And of course, it depends on the level of the tournament and the available resources. But one of the key messages from my presentation is that even basic equipment and training, and by that I mean an AED and staff trained in BLS, will save lives. And even when you do have the best equipment and the best staff available at a major event like, say, the World Cup, we shouldn't forget that the basic principles are the most important, especially in those first few minutes. And what is really nice for us to think about here is that we are now preparing for the World Cup, and this is where we can leave a true legacy for Qatar, and that is in training not only those people who will be involved in the World Cup, but those who will be involved in sporting events after the World Cup. So for me, this is a very important step in this whole process. Then we move on to the pre-match checklists, and this is an important step as well, and it's done before the tournament, during the tournament, and before every match. And it's all about checklists. So field of play staff should know the content of their bag by heart. They should check the equipment every day, and they use checklists for that. The player medical room and the ambulances need to do the same thing, and they need to focus on fine details. We're talking here about things like the expiry dates of drugs, electrical charges, spare parts for crucial pieces of equipment. And they should do this every day, and they should document this every day on a checklist. And of course, these checklists also includes the training that people do just before matches, on match day. The key, what we want to achieve here is that we want the team to be as slick as a Formula One pit stop crew by the time match day comes along in a major tournament. But then again, you don't have to be part of a major tournament to be this prepared. If you are familiar with BLS and you have a defibrillator, you can provide this kind of training to any team that's willing to learn how to use these equipment and how to apply this on the pitch. Of course, most of us will never see sudden cardiac arrest in our lives, and that's fantastic. But we do need to be prepared for it, and one of the first things we need to be prepared for is how to recognize it. Now, if you look on the left-hand side of the picture here, you'll see this player going down. And what I want to show here is that this doesn't look to the uninitiated like a cardiac arrest. Look how he's moving, he's still breathing, he almost looks like he's still talking, but that is actually a cardiac arrest. So then the next step is to activate the plan. And this is where FIFA has made some big changes to the rules some years ago now. And the rule is that when you see what we've seen in the previous slide, which is a non-contact collapse on the pitch, we assume that it's a sudden cardiac arrest until proven otherwise. And in that case, the field of play teams do not need to wait for the referee to call them on. They can just run with their equipment, and the team physician can run on so that they can start the resuscitation as quickly as possible. So we want no delays. And then you have to make the diagnosis of sudden cardiac arrest, and this is just using the simple ABCs. And the key thing here to know is that if there's any doubt, we treat it as a cardiac arrest. In other words, we start with the chest compression. So if you can't feel a pulse, you start straight away. And the chest compressions are pretty straightforward. This is what it looks like. So it is performed with straight arms, locked elbows, fingers are interlocked at the lower half of the sternum. The rate should be about 100 to 120 beats per minute, and the chest is depressed about 5 centimeters. So you have to allow for full recoil in between the chest compressions. And this should be uninterrupted. The only time you should interrupt chest compressions is when you attach the defibrillator and you do the shock, in the beginning at least, until you hand over to the definitive team.
And then the AED. This is, in my opinion, probably arguably the most important step in the whole process if it's a shockable rhythm. And we aim to deliver the first shock within 2 minutes if we can. And this is just an arbitrary number that's picked not because we have a randomized controlled trial to prove that this is the best time, but because most of those players who've survived have actually had their decompression within 2 minutes or round about 2 minutes. And nowadays, these AEDs are so easy to understand and read that anybody can do it. And then, of course, finally, it's important to transfer the player directly to a definitive care centre. And we don't want to take them via the player medical room. And the reason for this is that in a definitive care centre, it's much easier for people to deliver advanced care without interrupting the basic care. Whereas if you take them to a player medical room, you're just delaying things. So to summarise then, when we are faced with a sudden cardiac arrest on the pitch, the most important thing is don't panic. Keep it simple, and the way we achieve those things is to plan, to prepare, and to practice. I've now shown you the planning and the preparation, and it's all available in the article and in the FIFA medical bag, and now it's just a matter of going to practice it. And with that, I want to return to this Ericsson case. The medical team, and in particular the players, responded really well to this terrible event. And I'm really wondering whether it's time for us to start thinking about routinely training more than just the medical support staff. And here I'm talking about the technical staff, coaches, and possibly even the players in how to recognize sudden cardiac arrest and how to perform basic CPR, including the use of the defibrillator. So I want to show this video. I'm sure that we've all seen it many times over, just to remind you of how well things went. And again, please be sensitive to the needs of those people who might be affected by this, and do not share it on social media. This is for us to learn important lessons. So you can see it's actually the player that recognized the cardiac arrest and is calling the medical staff on. The medical staff respond quite quickly. Things are well organized. There's no chaos around that player. Everybody knows what they're doing. And it's important to support the neck. People always talk about that, but we have to remember that the primary issue here is cardiac arrest. It's not a traumatic event, it's cardiac arrest. So you should protect the neck, but the key thing to get done is the chest compressions and the defibrillator. And you'll see we don't have a timer on this, unfortunately, but that the first shock was delivered within less than 2 minutes. And there you see it. And he only had one defibrillation. My understanding is he only had one, and then the cardiac rhythm resumed. So, and this is the result. Thank you very much.
Thank you very much, Celeste, for that. I wonder, Ian, would you be able to introduce our panelists now, please? Thank you.
I would love to. Thank you very much, Liesl. There are two. Mats Borgersen, I know quite well. Met him at a UEFA conference a few years ago, and I've actually had a drink with him in Blackheath, near where I used to live, where my daughter now works, actually, in the Crown. But Mats is a well-known sports cardiologist, professor of head of the Centre of Health and Performance at the Institute of Neuroscience and Physiology in Gothenburg. Been on loads of steering boards and national and international societies. He's the doctor of the Swedish women's national football team as well, a member of the European Sports Cardiology Group, and also the Task Force of Physical Activity for the WHO network. So welcome, Mats. Nice to see you again. And Jan Till is really someone. Hi, Jan. Is really someone who's the queen of channelopathies in the UK. So I know her well from my time at the FA, and she works at the Brompton and St George's Hospital, which is in southwest London, the posh part of London, really. But she cares for both adults and children, and her drive really is to prevent sudden cardiac death in the young and identifying ways that we can improve the care of patients and families living their lives with inherited cardiac conditions, something that we're also involved in professional sport. She's co-director of Children's Services at the Royal Brompton and joint chair of the Children's Cardiac Services Joint Leadership Group at Guy's and St Thomas's. Good morning, both of you, and thanks ever so much for getting up so early. So, I mean, I'm going to dive in really, and just, we've got a few questions sort of lined up, as you can imagine, on this sort of thing. But the one thing I'm interested in, that the four cases that I sort of half presented were all older players who'd been screened on an absolute regular basis, and you'd expect that even if they had a false negative on one or two occasions, for goodness sake, they'd get picked up in the end. Is there something that's happened to them over time, being elite footballers, and that has changed the architecture or the function of their heart to suddenly make them more susceptible to issues, cardiac issues?
You want to start, Jan, or?
Well, of course, Ian, as you know, there are many conditions that we are never going to see on cardiac screening, unfortunately. And some of the newer cardiomyopathies, the arrhythmogenic cardiomyopathies, such as filament C, RBM20, there's a whole bunch of them, PPA2, which we've learnt about in the last few years, really from the fantastic work in CMR imaging and together with genetics. So those kind of conditions we're not going to pick up very easily, even if we do the best informed screening on ECG, even followed by an echo. Because if these patients, they come to you, and unless you go for the MRI, you can't see the fibrosis in their tissues. And so there are those. There's also anomalous coronary arteries that really leave no clue. But I mean, I'm sure that wasn't the case with Christian or Fabrice. So there are conditions, and those conditions can increase with age. So although they might be there in young players, they could get worse as time goes by. I guess there's the other problem that, we know in things like those arrhythmogenic cardiomyopathies that sometimes you need a trigger, and the trigger seems to be a viral infection. And maybe they weren't such high risk before, but as time goes by and a viral illness just triggers that extra bit of fibrosis, which then provides the substrate for the sudden ventricular arrhythmia that takes them down on that particular day.
Thanks, Jan.
Yeah, I might add to that the good news is that we can find some of the major causes of death in these young athletes, say the hypertrophic cardiomyopathy and so on. We have a pretty good chance of detecting that during screening. But as Jan said, there is other things we cannot see. I mean, the morphologically quotation normal unquotation heart and genetic disease and ion channel diseases may not be able to detect. But I will also say that it's not only the ECG, but some of these you may detect on family history or symptoms. So I think we can do more, and we have a registry in our country on all deaths below the age of 35, sudden cardiac deaths. And what we find out when we do interviews with the survivors, or not, I mean the surviving family members, I would say, is that the family history is actually higher than we thought before. Then when you really ask for symptoms and you find out, so that's also important. Although ECG is the most sensitive screening tool, but having said that, we can detect a substantial number, but far from all.
So I wonder if I
Thank
can
you.
ask Jan, just to connect on with what you said about the trigger, the viral trigger. One of the questions that I've heard people ask is whether they can, with the global pandemic that we're facing at the moment, can we expect to see more of these events? And should we be doing something different in terms of screening to try and pick them up?
I'm not sure that we have actually got evidence that we are seeing more. And that comes down to registries and things. So it will be interesting probably to look back. But we do, I think it's now well documented in arrhythmogenic cardiomyopathies that viruses can act as a trigger and progress the disease. So, you know, for someone with very minor things on MRI, you can detect a virus will speed that fibrosis up and they'll be in trouble for a few months, and then it goes back again and they won't have any symptoms. So there's this constant increase in fibrosis and scarring, which eventually accumulates to a state where they will suffer. I mean, COVID is an unpleasant virus. That's the understatement of the last 18 months, isn't it? But it can really, really affect your heart. And we are seeing people with scarring after COVID. In long COVID, we've got certainly a lot of evidence for that. So yes, it makes theoretical sense. I'm not sure we've actually got evidence for it yet. What we could do about it, gosh, I don't know. I guess all your players, Ian, are going to be double vaccinated. I mean, get them vaccinated fast would be the best thing I could suggest.
Yeah, I agree. I mean, the whole COVID thing it's gone mad. We've got a question here typed in. When you say detecting symptoms, what symptoms are significant, even if an athlete has a, inverted commas, normal heart?
Oh, I guess that's a question for me then. So the symptoms, we know quite well which symptoms are associated and which you can find before. And the most things the red alert, so to speak, is that if you have, of course, chest pain during exercise, but also syncope during exercise. And I would say it's very important that it's during and not, just after the completion of exercise session and so on, or palpitations and arrhythmias during exercise. I would say those are the main things. There are also more diffuse things like dyspnea and fatigue, which it's very diffuse, and how could you delineate that from other causes? But these are the symptoms you should look for, especially those exercise related symptoms.
Thanks. Thank you. Can I ask another question? I'm sorry about this. So, given what you said, Jan, about cardiac fibrosis, and given that of the fact that a couple of the players that I mentioned were older players and had cardiac problems, having had normal screens in the past, is there a case for every 5 years or whatever it is for elite players to have a cardiac MRI? Is there a place for that? Is it a resource issue? I mean, what do you think?
Well, I've been thinking about this a lot too, Ian. I mean, from where I'm sitting, I see a lot of people where the only way we can detect something is on MRI. And, they might present, as Matt says, with fairly nebulous symptoms, but you've taken it that one step further and you pick them up. And of course, if you look at the individual case, the MRI has saved their life. It's probably a resource issue, isn't it? We've been fighting to get them screened with, in this country, the national screening program for non-athletes won't even, is humming and hawing about doing an ECG. You know, it's been fantastic, all the work that Sanjay Sharma and Anil Notra and that group have done, because it's got the false positives down, which has made it affordable now. So I'm really hoping in the next year or so they'll bring an ECG into the national screening program. I don't think that's the problem with MRI. I don't think there are false positives, although of course we'll be on a learning curve, just like for the ECGs, for a few years, I suspect, trying to work out what we should take as really significant or not. I suspect it's resource, isn't it? But it to me, I don't think I can advocate doing MRIs. It'll have to be fought through every governing body. But if you're the individual, it looks like a very good thing to do. I mean, of course, that would pick up anomalous coronary arteries, which still are 0.38% of sudden cardiac deaths. They scare me, anomalous coronary arteries. I see younger people who collapse all the time, or with chest pain. And you're going to miss those. I think all of us are going to miss those, because we do the usual tests, and you're never going to pick up an anomalous coronary artery unless you get a really good echo with someone looking at the coronary artery course, and then follow it up with an MRI. But you're still going to miss the channelopathies.
Yeah.
So yes, Mats is right. You need a low threshold for doing an exercise test, where I think we're much, much better now on picking up long QT. 25% of long QT is still not evident on your resting ECG. And we will pick up the rarer condition of CPVT, which has an absolutely barn door normal ECG usually. I mean, some of them have sinus bradycardia, but in an athlete, that's normal. So if you want to pick up those, a low threshold for exercise testing. And I don't know what you do, Mats, but I'm probably outside what is recommended, because I exercise test everyone who comes towards me, just to be sure, because I've seen so many cases easily missed.
Yeah. I have a few comments there. I mean, if your question was if I use the exercise test, I do a lot, and even though in regular cardiology, exercise testing is now less common because you have the imaging methods, I think in athletes it's absolutely essential, because coming to older athletes now, which we don't really talk about here, it's coronary artery disease, right? And then it's not enough to do the anatomical evaluation. You have to do also functional evaluation on top. And that is, you cannot just look at the motor in a driveway. You have to test drive and look for arrhythmias and so on. So exercise test has a really important role in especially for older athletes, but also for younger, I would say. You could also use other stress tests equivalent, of course. Coming back to the other reason, should we do MRI on everybody? I think that MRI and imaging has a real great role in the second phase, so to speak. When as soon as you have any symptoms, any ECG abnormalities and so on, you should go for that. And we have learned also that if you have a seriously abnormal ECG, the echo is not enough. You must, I mean, today it's standard to do an MRI also, and possibly even to follow these, because sometimes the ECG changes may precede the phenotypic changes in cardiomyopathy, for instance. So no, I think ECG is really sensitive, and also the ECG changes tend to come before other imaging changes. So I'm quite happy with the today's screening in a way, and I think we should do it on everybody, of course, and do it more thoroughly and evaluate all the parts in it. imaging, MRI for everybody. I don't think. I mean, you also said that maybe no false positives, but we do know that older athletes, runners and so on, may show some slight fibrosis here and there, and that was also shown in some COVID cases. So we really don't know the specificity of that. No, it has a great role, but not for everybody, in my opinion. Not now.
Thank you. Paul Dykstra, what about the potential harms of screening, overdiagnosis, overtreatment, especially in the context of low prevalence conditions and methodological heterogeneity?
Well, you're right, Paul. I mean, that's what the argument against screening is, isn't it? That you're going to overdiagnose and scare a lot of people, potentially ruin careers, people living with anxiety over a condition that they might not have. I think, as Matt says, the ECG is now an extremely good tool in that it is very sensitive. It was the specificity that we had trouble with, but with a lot of the work that's gone on, there's been paper after paper trying to hone down on the ECG and make it a usable tool. So I think anyone in screening is much better at dealing with this now. We certainly have, we run a sort of cardiorespiratory screening unit here for younger people. Sabia Gatti does the older customers, and we have psychology attached to that because, whenever you question something on an ECG, it comes with a great deal of trauma for people. But I think we're getting better and better. I would like to think so.
Yeah, and the opposite is also true, of course, that I've screened, hundreds, thousands of people, and not hundreds of thousands, but hundreds of thousands. And the athletes sometimes say, "Why didn't we do this before?" I see television, and I think this is actually making me more safe. And I think that's also you have to do. Maybe you can upset a few people, make them nervous, but the other part is also true, that they feel safer if you do it, and they say that of course we should do this. So I think it's both ways.
And I think it's really difficult. I mean, you talked about the trauma of the spectators, the trauma for those athletes, the footballers watching what happened to Christian Eriksen must be tremendous. Is this going to happen to me?
Yeah.
It's a terrible situation for them, isn't it? So I think screening can have really positive effects because if you're an athlete, you've got to go out there, and as Ian said, you're concentrating on your game. It's a really mental, psychological thing, sport. So you've got to go out there in the knowledge that you're safe. It's and if we didn't pick you up on screening, that there would be that tremendously planned. I mean, I'm so. I think your plans are fantastic, Celeste. I think it's a great approach that you're using. I think simulation would be great if I can comment. I think doing resus is bad enough in the hospital. I think once you get outside a hospital, it becomes a bit of a different ballpark, doesn't it? And so having plans and practice sessions in place is a brilliant idea. And I think doing it in front of thousands and billions of people watching you is an even more worrying. So I think your plans are brilliant. And I think you're right. Maybe the players, that was his team captain who first spotted him down and got there very quickly and called. I mean, that was just brilliant of him, because the problem is recognizing someone go down, and everyone has got to be alert to that, haven't they? Because you just can't watch all players at all time.
Yes. Another question: at what time do you start screening an ACE youth athlete? Are there different types of disorders? I mean, I think you touched on this, Jan, children and teenagers, or are they the same? Dr. Mohammed had a child that died in a playground, age 5.
Yeah, we see small children. I've just been dealing with a cardiac arrest in a 2-year-old. So it happens from being a baby upwards, and the conditions do vary. We see a lot more CPVT, catecholaminergic polymorphic VT, in the younger patients. The prime time for that presentation is sort of 7 years to about 12 years. So we see far more of that. We see less. We see HOCM. We see less of arrhythmogenic cardiomyopathies. They sort of more often present in teenage life. And we'll see anomalous coronary artery and long QT. So as I say, I have a low threshold for exercise testing. We get 4.5-year-olds on the exercise treadmill and get them running.
Good.
Ian, can I comment on the resuscitation? Is that?
Of course you can.
I don't know if it was Celeste or Liesel that said something about the survival rate was quite low, and that's true for out-of-hospital cardiac arrests in general, in the general population. In our country, we have this. We're good at registries, so we have registries on all the deaths happening outside hospital, and the survival rate is about 18% or 19% in the general population. But as we can show, exercise-related sudden cardiac arrests were much higher, up to over 50% survival rate, and it's also even higher in arenas. And of course, that shows you. So the survival rate for 30 days was between 55 or 60%, something, 55, I would say. And that shows that survival, possibly the trigger of exercise is actually causing this in a little bit healthier individual than the normal non-exercise related deaths, because the survival is substantially higher. And the other reason for that is, of course, that they are more often observed and faster heart and lung resuscitation and defibrillation. But the ambulance is not faster. So the survival rate is that's a good thing, that the survival rate actually is higher. And also in younger, we can see in our registry, also in younger people, it's higher. Sometimes you say it's not so high in young because they have an underlying morphological disease, but we cannot see that actually, that the survival is actually also high in the young.
In fact, you're absolutely right, Mats, and I didn't include all the numbers in my talk, but in one of the studies, they're talking about survival rate up to 89%. That is if things are started as very, very quickly, and then it drops by 7 to 10% for every minute of delay in getting the proper CPR going. And this is actually, I just wanted to, I see that Aston asked a question about the referees, and I think this is very important to address that. Two parts to that question. The one is referees, of course, are treated like athletes, just like the players. So they have the same screening and the same management. But the other side of the coin is that in the FIFA World Cups, the referees actually receive formal training in how to recognize sudden cardiac arrest and how to treat it. And you're absolutely right. I think this is where football players have a massive advantage, because they are picked up immediately and treatment is initiated immediately by everybody around them, not just the medical team. And it would be wonderful if we could extend that to the players. Of course, as Ian said, players are busy with the tournament and maybe they don't want to think about these kind of things. So maybe in a World Cup is not the time to train players for this kind of thing, but maybe out in the clubs, or in the national teams when they're doing their training camps, that might be a good opportunity to get people trained up about how to manage.
I agree.
I agree, Celeste. I always say it's fine if you have a cardiac arrest in a big stadium with skilled practitioners recognizing and then treating. But if you're on pitch 15 in a training venue and there's no one around and you're doing a session in the afternoon with a player and the player collapses, everybody needs to understand how to do CPR and how to alert everybody of what's going on with accurate information and communication. Agree.
And to be
Can
honest,
I-
I think, sorry, I'll quickly finish. What I really like about the World Cup here in Qatar is because it's such a small country, and here we have an incredible opportunity to leave that kind of legacy, where we can train people for after the World Cup is finished, people who are going to be on the field of play for the not so glamorous events, but who know what to do when something happens, because if it doesn't just happen in elite athletes, of course. Sorry, thanks.
So I just, there's one more really important question I think we need to touch on before we go, and that is the question of return to play. So this is from Andreas, who's saying that the question, will Christian Eriksen be playing again? And then talking about the recommendations of going back to play with implantable defibrillators. And I think in a way this touches also on the whole ethics question of when you pick up a player who is at risk of sudden cardiac arrest, but they want to continue playing. It's one thing for us to pick it up, but it's something entirely different to stop a player from returning to their career and what they love. Maybe I should ask Mats first, what do you think about that? And then maybe get Jan's opinion too.
Yeah, I mean, it's a very complex question, and it has been addressed both by us in the European Society of Cardiology and the American counterparts in the American Heart Association, for instance, and the role and importance of shared decision making. It has been emphasized, so that's always there. Having said that, there are players playing with ICD and also football players at the highest level, and should you play or not? I mean, in this case, I cannot comment on this particular case because it's it's up to the player and his team of physicians, of course. But in general, the recommendations say that you should really consider which underlying disease you have, and I think that's the most important thing. If you have a disease that might progress with athletic activity, for instance, a cardiomyopathy, I think that's a reason to be very cautious. Because then you get more of these things and events, possibly. The other thing is that you can have inappropriate shocks if you have an ICD, or also or which is very unpleasant, of course. And the third thing is that if you have a traumatic sport, contact sport, being goalkeeper in handball or even football, you might injure the system, and then it doesn't work when you need it. So, on the other hand, it's also the player's discussion with his or her doctor. So it's a really complex situation, and there are examples. But I think ultimately it's an individual decision, and but you can have also be part of sports where it's, even if you're saved by the defibrillator, it would be a very difficult situation. For instance, auto driving, racing, yes, or being out in a wilderness in a canoe. It doesn't help you if you get resuscitated if you fall over. So yeah, you have to consider a lot of things. It's complex and it's difficult, I would say.
Yeah. And your opinion, Jan?
Yes, I think, well, Mats has summed it up, isn't it? It's a very difficult area, and it certainly depends on the condition. So the arrhythmogenic cardiomyopathies, you'd really want to think whether you were doing such intense exercise. But, we're making roads into this, aren't we? I think we're getting better even at this. Rachel Lambert did that fantastic study where she looked at people taking part in competitive activity with defibs in. Look, as implanters, we're usually stuck with dealing with the complications of defibs too. So we're very worried about what's going to happen to the system if you're doing competitive sport. And the evidence actually was that there were less problems than any of us feared. So yes, Matt says it. We need to look at the condition. You need to look at the sport that the person is thinking about, and then it needs to be a decision between both you and them. And it's an awful area, isn't it? Your heart goes out to these people because they've trained so hard and done so much to get where they are.
Absolutely. So I think, Paul, we're probably at the end of our meeting, right? People need to go to clinics.
We
I'll
are,
hand.
and
Hello, Paul.
good morning, Mats, good morning, John.
Paul, can
Yes,
I add?
yeah.
Paul, can I add just one thing in the final? Is that possible?
You can.
And I would like to emphasize that we talked about screening today, and we talked also about the possibly that you miss some cases, of course, and also the use of or the need for a good medical action plan. In our country, with this registry with all cases, we can actually see that in the 90s, 1990 to 99, compared to 2000 to 2010, the cases, number of cases of young athletes dying in our country was half the coming. And we cannot say if this is due to screening, because we didn't have that before. Is it the more widespread use of defibrillators in the society? You know, we have them in taxis, airports, arenas, and so on, and the medical, or more knowledge also, I would say, recognizing these things, and also in our community, because way back we thought it was myocarditis in all cases, and now we realize it's more inherited disease and so on. So what I'm trying to say is that the combination of these three, we don't know exactly which is most important, but we need all, and all these things together has actually halved the risk, and I think that's great. And therefore, in this case, it was shown that maybe screening didn't pick it up, but medical action plan worked. That's a good thing.
What a wonderful way, I think, to end this lecture, to end this the academic year, actually, as I've said, for the Tuesday lectures, and the 3-year accreditation cycle for this grand rounds or Tuesday lectures here at Aspetar. But the good news is this is not the end of the conversation. There will be lots of opportunities to continue what we've done today. And one opportunity will be next year in early March. Aspetar and Qatar, actually, with our partners, AFC is hosting the 7th AFC Medical Conference. And cardiac screening, managing cardiac events on the pitch will definitely be an important session during that conference. Huge thanks, Dr. Jan Til, Mats Börjesson, Celeste Geertsema, Liesl Geertsema, and Ian Beasley. It was a wonderful hour to spend with you. Lots of unanswered questions, but as you've said, we've gained a lot. And only thing for me is to wish you all a wonderful day and a wonderful summer break for those who can travel or those who can't travel in your own country. Stay safe, and we look forward to see each other again here in September. Thank you very much.
Thanks all.
Thank you.
Thank you very much.
Thank you very much. Thank you.
Thank you.
Bye.